Be free, my child. Breathe. Fill your lungs with life.
Every day, thousands of children suffer from asthma, a life-threatening disease characterized by a tight chest and shortness of breath.
Asthma is a chronic disease affecting over 300 million people worldwide. Now, according to a report by the Global Initiative for Asthma, South Africa has an estimated 3.9 million asthma patients, and 1.5% of them sadly die on an annual basis. South Africa has the world's fourth highest asthma death rates among the 5 to 35-year-olds. Now, World Asthma Day was celebrated on the 2nd of May, and this day was dedicated to the prevention and treatment of asthma. The aim is simply to decrease the number of people who die from asthma attacks. So today we focus our discussion on all important aspects of asthma. And assisting me in this is a guest panel comprised of a pulmonologist, a pediatrician, the chair and founder of Allergy Alive, who will also represent the Allergy Foundation of South Africa. We also have a person living with asthma, and lastly, a researcher. We invited an interesting medical digital instrument called the Asthma Grist, and he'll be joining us from our Pretoria studios. Now, if you want to be part of this show by asking the panel some questions or simply just sharing your views with us, in that case, the number to call is Johannesburg 714-6918 or 6919. You can also tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, yes, and learn from this exciting show coming to you just after a short break. I'm Dr. Seloma Daung, and this is Health Talk.
Asthma is a common health problem that affects many people from all walks of life, young or old, regardless of race or gender. During an asthma attack, the air passage of the lungs becomes swollen, making breathing difficult and narrows the airwaves. Cynthia Mufugeng, a mother of 4, suffered her asthma attack after she experienced an unusual cough and short breath. Mufugeng says her battle with the chronic condition started at an early age.
When I was young, my mother said it started like pneumonia after I was drinking paraffin or what, when I was young. Since from that time, my lung was damaged, my left lung. I have to suffer for, it's more than 27 years I'm using the pump. Then after that, the doctor said my left lung is not functioning.
The impact of asthma varies from person to person. Due to the extent of her condition, Mufugeng is no longer able to participate in other activities.
I'm fine, but my problem is one, I can't run. I can't dive, I can't do everything, I can't walk with the steps, and I have to go slowly. I must take everything must take it slowly.
The unemployed mother regularly visits Charlotte Maxeke Hospital to see medical practitioners every 3 months for her lung function test. The test is conducted to check how well your lungs are working and how asthma affects your breathing. Mufugeng also says the condition has financially crippled her.
I survived because of my family, but now I have 6 months now I have a grant now for 6 months. Temporal disability grant.
Because of asthma?
Yeah, the doctor gave me. I started last month in January.
So then the grant isn't enough for you?
It's not enough, but because they say it's enough, the doctor says it's enough for me so that I must buy something what I need or food.
Mufugeng experiences physical activity limitations or suffers symptoms during physical activities. She says her physical mobility is dependent on the inhaler.
When I feel like I'm blocked, because even now I can't go from here 356 to the red block. I'm getting tired. I have to stop and then I must use my pump. Then from the red block to the out to the gate, I have to stop again. I must use my pump so that I can go to the taxis.
All right, so let's learn more about this condition called asthma from my three special guests. First up, next to me is Dr. Morimisi Mukansi. Dr. Mukansi is a specialist pulmonologist based at the Helen Joseph Hospital and is head of ICU at there. Welcome to Health Talk.
Good morning, Dr. Mataung and the listeners.
All right, and next to Dr. Mukansi is Dr. Meshandri Naidu, who's a pediatrician in private practice in Parktown North. Now, Dr. Naidu has a special interest in allergies and holds a diploma in allergology, if I can say it. Welcome to Health Talk.
Morning, Sally.
How do you say that?
Allergology.
Allergology.
Yes, thank
Which
you.
is?
It is the study of allergies.
All right, okay. You're going to tell us more about that a bit
Yes.
later. Welcome to Health Talk.
Thank you.
And of course, next to her is Hayley Keds. Hayley is chair and founder of Allergy Alive, and she also represents the Allergy Foundation of South Africa. And I might as well just add that she's also a psychotherapist by profession. Welcome to Health Talk, Hayley.
Thank you very much for having me, Selo.
All right. You're going to tell us more about this organization, the two organizations that you represent. But first, let's start with Dr. Mukansi. Let's start with the basics.
Good.
Asthma. What is asthma in simple terms? How does it happen?
Asthma is a chronic inflammation of the airway. And by that, I mean the swelling of the airway, amongst other things. It's irreversible, and it makes the airway irritable. So we say it's hyper-responsive. And because of that, you get lots of mucus secreted to block the airway. You also get the muscle that's around the air pipes excited, and then those two things in the main lead to the blockage and then the subsequent symptoms of coughing, whistling sound, which we call a wheeze, and maybe tightness of the chest and shortness of breath. So in short, that's what asthma would be.
All right. Dr. Naidu, now, obviously you deal a lot more with children.
Correct.
And how easy is it to identify in children?
That is a very good question, Selo, because diagnosing asthma in children is extremely difficult. And because testing and diagnostic testing is so difficult under the age of 5,
Right.
a detailed history and a clinical examination is invaluable to the diagnosis of asthma. So spending time with a mom who gives you a detailed history in terms of persistent coughing, wheezing in a child, shortness of breath, how frequently does this happen? Those are important aspects in a history taking. In addition to that, are there associated allergic conditions? Does the patient struggle with allergic rhinitis, eczema? Those carry heavy weights in terms of asthma prediction in children. And I think more than that is the genetics.
Right.
A family history is extremely important. A family history, maternal history specifically, of asthma carries a huge weight. And we talk about an asthma predictive index in young children, which helps us then diagnose the condition of asthma.
Right. How common is it in children? I mean, earlier I said it affects over 300 million people worldwide and so on. In children, how common is it?
Asthma is actually one of the commonest chronic childhood diseases, and it affects about 20% of our population.
20% of the population or of the children?
Of children.
Okay.
Okay.
Right.
And looking at it globally, and you did mention this earlier, that we are ranked 4th worldwide when it comes to asthma mortality. So that is significant.
We're going to come back and ask you, should it be?
Perfect.
That later on.
Perfect.
Dr. Mukansi, how common is this in adults?
Quite a common disease, Silo, and like we have already estimated, you have about 300 and above million people worldwide. So it's quite a significant disease. It's amongst the 4 common lung diseases.
Okay.
Yeah.
All right. Now, let me invite a comment from Hayley. Hayley, you're a chair and founder of Allergy Alive, and you also represent the Allergy Foundation of South Africa. What are these two organizations about? Association with asthma?
It's come to our knowledge that there's very little awareness around allergic disorder, particularly in South Africa. And if you look at the world allergic disorder community, what's being understood now is it's the largest non-communicable disorder in the world, i.e. severe allergic disorder, and asthma forms part of that. We also know it's a very debilitating condition. And in order to normalize our community's lives in schooling, in restaurant, going out, activities, we need to develop great awareness, and we need to raise funds for research, etc. We need to improve quality of lives, and we need to prevent unnecessary deaths. And essentially that's why we've come into being.
Okay. So you have Allergy Alive, the Allergy Foundation of South Africa. What's the difference between the two?
The one is a patient organization. It's the national representative of patient organizations. That's Allergy Alive. And the Allergy Foundation of South Africa is medically based.
Okay. And what do the two do?
We fundamentally raise awareness, and we have various projects to build funds for research to improve treatment. We want to develop accessible treatment across socioeconomic, racial groups in South Africa. We're really aiming to prevent unnecessary deaths. There is a case that I cite in Canada where there was a little boy, an asthmatic, who was not allowed to carry his asthma pump at school, and he died. It's now called Ryan's Law. And what we're seeing internationally, that only after tragedy and deaths of children has legislation changed. So really, as organizations, we're trying to change macro environmental perspectives and legislation to normalize the lives of these people and prevent these tragedies from happening.
Dr. Mukanzi, let's get back to the signs and symptoms and basically, you know, the clinical course. Earlier we showed a clip where the lady was saying, you know, she can hardly walk a few steps before, you know, she's feeling breathless and she's got to use a pump. Is that how the normal disease, carries on?
Yeah, obviously there's got different grades of whether it's mild, whether it happens all the time, and whether it's persistent and up to from mild to severe. But what it is in short, the four symptoms I've mentioned in my introduction, that you get cough, you get the whistling sound, and you get tightness of the chest, and then you may also get shortness of breath. So those in the main would be the symptoms, and it depends on the grade of the severity of your asthma.
Is it a condition that worsens over time?
Depending on whether you get therapy or not. If no therapy is administered or you're not treated properly, you get worse over time. You may even get to the time where you have fixed airway obstruction. That means your lung function will not revert to normal because it hasn't been treated and you have been asthmatic for a long time. So that means there's poor control, and as a result, your lungs get used to staying in an obstructed condition, and just like a smoker would be.
Okay. All right. Let's take Colleen on the line from Johannesburg. Colleen, welcome to Health Talk.
Hi, guys. How are you? Okay, I've got a problem. I haven't been diagnosed, but I've got two brothers that have, they've been diagnosed with asthma. But mostly when I go to bed in the evening, especially when I give my toddler a bottle to go make a bottle and I go to bed, my chest tends to close, I wheeze and I cough. But I take a Ventis pump. Can I do that, or do I need to have a proper checkup?
All right. Did you get the question, Dr. Mukanzi?
Yeah, I think the best thing is always to have a checkup. One should never self-medicate because you may be treating something that looks like asthma with the same medication. I mean, one of the things that comes to mind is reflux disease, which may irritate people and they end up having shortness of breath. They may get to asthma, but in the main, you may realize that you need other treatments other than the pumps. So I would suggest that being around in town where there's lots of hospitals that can attend to it, the best thing is be checked so that you can share the knowledge with your doctor, and then we get going.
Okay. Dr. Nada, earlier we spoke about different grades of asthma.
Yes.
You often hear parents saying, the doctor said my child has a touch of asthma. Is there such a thing?
I think you're either asthmatic or you're not. In terms of classification and severity of asthma, that's generally done on initial presentation, because that guides us as health professionals in terms of how we treat our patients and in terms of stepping up our regimens. So we classify asthma as either intermittent or persistent asthma, and that is based on symptoms. So how frequently is the patient having daytime symptoms of cough, shortness of breath, wheeze? Are they having nighttime symptoms that's waking them up and causing restless sleep? And we're looking at their peak expiratory flow rate. So based on those 3 factors, we can classify as either intermittent or persistent asthma, and then grade it as a mild, moderate, or severe asthma.
Right. Okay, maybe this is a good point for us to break for a while. After the break, we now look at the impact and causes of asthma. Please stay with us. Welcome back. We're talking asthma, and we're going to learn just how this condition can impact on normal lives. And with me in the studio, help me with this discussion, is Dr. Muremisi Mukansi, who is a pulmonologist and head of ICU based at Helen Joseph Hospital. And we also have Dr. Meshandri Naidu, a specialist pediatrician in private practice in Parktown North in Johannesburg. We're now joined by another special guest, Rehana Sidat. Now, Rehana has been asthma sufferer or living with asthma, whichever way you want to look at it. And this has been over the last 10 years.
Yes.
Welcome to Health Talk, Rehana.
Well, thank you, doctor.
All right, let's stay with your story. You say that you were diagnosed with asthma about 10 years ago.
Yes, in 2007.
Tell us about what happened then.
What happened, I used to get chest pains and irregular heartbeat, and I used to wheeze and cough a lot and a lot of phlegm on my chest. So I was in my gastro clinic. The doctor saw me, he did an x-ray, and then he sent me to the asthmatic clinic. Then I went to the asthmatic clinic, and the doctor saw that I had severe bronchitis at that time and a touch of TB. And then she started treating me. And like now it's 10 years. After 10 years, I can say that I'm feeling much better, very much well controlled with asthma. Don't suffer as the way I used to suffer in the beginning.
Okay, we're going to ask you about how you used to suffer exactly.
Yes.
Okay, but let's take Antoinette on the line from Cape Town. Antoinette, welcome to Health Talk.
Welcome, sir. Thank you so much. I have a question with regard to the diagnostic side of things. As a nurse myself, I've had this with my son, whereby when he wakes up in the morning, he sneezes until doomsday. He sneezes and he makes this noise like he's scratching on the nasal passages, like the upper nasal passage. So he does this every morning when he wakes up. It's kind of like irritating to other people, but as the sun comes up, he then grows out. It goes out on its own. So I just want to know, where can he go for testing?
All right. Thank you very much, Antoinette. Dr. Naidu, I hope you heard the question.
A little bit.
This child, yes, the line isn't too clear, unfortunately, but the gist of it is that her child every morning wakes up with a congested nostril, something blocking, and it falls out on its own later on. I don't want to say what I think it is, but let's give it to you. Yeah.
Okay. Caller, I think it sounds very much like you're describing a pattern of a chronic rhinitis, which could very well be allergic in origin. So that does need to be looked at closely in terms of diagnosis and finding out what the trigger actually is for the rhinitis. Now, allergic rhinitis is a condition that is associated with asthma as well. And we find that 80% of asthmatics may have allergic rhinitis.
Right.
And the control of asthma is actually dependent on controlling the rhinitis as well.
Okay. I need you to keep that at the back of your mind, because
Perfect.
I'm going to ask you again about allergic rhinitis when we talk about other conditions that are related to asthma, but we're going to do that in the next segment. Let's stay with Rehana for a while. Rehana, you said that you used to suffer a lot with asthma. Just describe to us how that was.
Yes, my nose used to be very congested as well.
Yeah.
And I used to be on the nebulizer about 4 times a day. I used to use it like daily for like a month.
Yeah.
And then, like I said, when I got treated, I got better. Like I couldn't breathe, I couldn't walk much. When I used to get walk, I used to get tired. And my chest used to wheeze, especially at night. Normally in the day and night, but then afterwards it was just night, mainly at night.
Okay. So what type of treatment are you on now?
I'm on asthmatic pumps.
Right.
I'm on a pill that's called Tropez, which I have with me.
That's all right.
Yeah,
That's
this
okay.
is the Tropez. I take once a day, which helps the airways. It helps to breathe, helps me to breathe. So this really helped me a lot.
Okay.
And I am on Floma's nose drops also, because my nose is always like wet. And when it's rainy and winter, then normally rainy, an allergy reaction I get, which is like behind my knees, you know, and here between my...
Yeah.
yeah.
Okay,
So,
all right. I think a very important point, a few important points she's raising, which links up to what I'd like us to discuss. You know, you described earlier that, you know, obviously there are certain factors that can trigger attacks of asthma. First of all, perhaps can you just describe to us what is an asthma attack, and then we can talk about what triggers an asthma attack.
When we say someone has an asthma attack, what we're saying is that perhaps their symptoms are worse than what they usually are. So they have an exacerbation or an attack. That's what it is. All of a sudden, the cough, the tightness of the chest, the breathlessness, and the whistling sound are exacerbated. So then we call that an asthma attack.
It's pretty much the same in children, isn't it? So?
Similarly, so not all children with asthma wheeze.
Yeah.
So a lot of them may just present with a cough,
right,
or shortness of breath.
Right.
But yes, very similar symptoms.
Okay.
To others.
Let's talk a bit about the triggers now. What triggers asthma attacks, as it were?
Yeah, it's a lot of things, but in the main, Rihanna has already told you about the weather, that when the weather changes and it's cold, it becomes a problem. So that may be one, cold weather. Sometimes exercise does do it. Sometimes particular medications like the group of medicines called non-steroidals, aspirin and those type of things, or even beta blockers, they may close your chest. And sometimes it's seasonal, so when those that have a pollen allergy, when it's spring, then they may have an exacerbation. Obviously, sometimes it's those that don't take their medicines or are not taking their medicines well. And sometimes it may be work-related. If you work in a place where they do painting, you may find that that is a problem. And even in the household dust mites, and maybe the animal dander that they put up and the fur that comes from some of the animals in the household, those are nearly the things that would precipitate this.
So it's got a wide range of stuff.
Quite a wide range.
What about in children? Of course, you know, perhaps we're now dabbling in your area now of expertise. Allergens, different types of allergens. Tell us a little bit about it.
So firstly, I think I always like telling my patients that it's the genes that load the gun, but the environment that pulls the trigger, and specifically so in asthma. Viral infections in children are actually one of the biggest triggers of asthma exacerbations, especially in children under the age of 5, school-going, creche kids. You know, they pick up common respiratory viruses, and then that causes severe exacerbations. And specifically, 2 viruses of note there's been a lot of research into, and one is the respiratory syncytial virus, which commonly causes bronchiolitis in children, and the other being rhinovirus, which is known to be a common cold virus, but actually has been shown to cause severe asthma exacerbations.
We're going to come back because I need us to talk about the environment, but let's take Brenda from the Eastern Cape. Brenda, welcome to Health Talk.
Hi, speaking to Brenda. I've worked in a refrigerator. I come from a background with asthmatic, and I also suffer from sinuses. I've got a cough now. It's over a year. I've got it now. It's going for 2nd year.
Okay.
And I have been to doctors in and out. I've had x-rays, but there's nothing showing. I've had pain chest, but there's nothing showing in the x-ray.
Okay. All right. Well, Dr. Mukansi, we just almost running out of time. You've heard the question.
I've heard the question.
Chronic cough, not abating. Your thoughts? What should she do?
One must worry that a chest X-ray alone is not enough. Perhaps to do a lung function that would help and see whether there is any evidence of obstruction or not. And maybe to even examine the ear and nose like we talk of rhinitis, just make sure that that passage is fine. But their work environment, the cold weather, could precipitate asthma.
All right. Okay. Okay. All right. Well, perhaps let me take this opportunity to thank Rehana Sidat and wish you all the best in your life ahead, okay?
Thanks so much.
All right, we're going to go for a break. When we come back, we're going to talk about How asthma is associated with other conditions? Please stay with us. Welcome back. If you've just joined us, we're talking asthma. And with me in the studio is three special guests, Dr. Muremisi Mukansi, a specialist pulmonologist and head of ICU from Helen Joseph Hospital. And next to him is Dr. Meshandri Naidu, a specialist pediatrician in private practice in Parktown. And we rejoined now by Hayley Kedz. Hayley is the chair and founder of Allergy Alive, and also representing Allergy Foundation of South Africa. Now, before we start our discussion, I believe we have Bitumelo on the line from the Northwest. Bitumelo, hello and welcome.
Hello, how are you?
We're good, how are you?
I'm great, thank you. Yes, I just wanted to ask, my sister's daughter is 3 years, and she has been coughing a lot, so the doctor suggested that we give her Monty Air recently, like on her food, on everything, but still she continues coughing a lot.
All right.
So I just wanted to find out if it's okay for us to use a pump on her, because now the Monty Air is not really helping.
All right. Excellent question. Thank you very much. Let's hear a response from Dr. Naidu. Dr. Naidu, I'm sure you heard the question.
Yes. Boitumelo, thanks for your question. Monty Air is a drug that's used in the treatment of asthma. So it works on the inflammatory pathway, trying to reduce that and to control inflammation in asthma. We often tend to use it in young children for the ease of administering the medication, because like she said, it's sprinkled over food. But I think that if there isn't control, then she needs to go back to the doctor, because obviously we need to look at other factors. What are the trigger factors in this child? Could there be other allergens that are exacerbating the asthma? Is it a viral infection? Is it a creche-going child that's getting sick all the time? And possibly a corticosteroid inhaler or an asthma pump may be indicated. But I think that the doctor needs to reassess that,
right,
and add that on if necessary.
And I guess the important thing you're saying is that the decision shouldn't come from the family, but
Correct,
rather from the doctor.
Correct.
All right. Dr. Mukansi, earlier, we heard that obviously asthma may be associated with other conditions, other allergies that Dr. Naidu is going to tell us about. But let's talk about in adults now. The progression of asthma. We hear about conditions called COPD, chronic bronchitis. Just take us through all of these.
Yeah, COPD consists of chronic bronchitis and emphysema, so I'll group those together.
Yeah.
But what it is that as opposed to asthma, which is reversible, when you have what we call chronic obstructive airways disease, then you no longer are reversible. That means you cannot regain your normal lung function to what it was, and maybe your then activities of daily living will be affected. And
but how do you progress? Is there natural progression from asthma?
Natural, it should not. When you have asthma, it should be that when you treat it properly, it gets controlled.
Right.
But in those that are poorly controlled, there is a danger that then they will end up not being able to reverse, because imagine something being stretched and stressed for 10 years non-stop without any improvement, and you hope that it will revert back to where it was. So it's really that poorly controlled asthmatics may have fixed airway obstruction.
All right. And emphysema?
Emphysema, it's what we mean is that the air sacs are baggy and the airways, so they are no longer able to open and close and be able to discharge the contents properly. And as a result, then you may be prone to infections in the main, because then the lungs are no longer working well.
And then we hear, of course, that some people get to a point where they live on oxygen and have what's called chronic, bronchitis. Just tell us a little bit of that.
The most important function of the lung, amongst other things, is to get oxygen into the body and the carbon dioxide out. So you need a functioning airway and a functioning connection between the airway and the blood. And as you get chronically inflamed and diseased, then there tends to be scarring. And when you have scarring of any component of the way the gases exchange, then you virtually will not get oxygen from the 21% that the Almighty has given all of us. So then we need to supplement it and give you more oxygen so that you can then be able to these things. You know, diffusion means moving from the higher concentration to the lower. So the more we give you, then it will get to pass to the bloodstream.
All right, interesting. I'm going to come back to you, Haley, to get your opinion on all of this. But let's take Priscilla. Priscilla, welcome to Health Talk.
How are you?
Good, how are you, Priscilla?
Good. I've got a problem. Like I've been diagnosed by asthma since 1995.
Right.
So for the past 4 years, I didn't have an attack. I got an attack this year in January. So since January, I've been coughing, and I've been like in the morning, my chest will be blocked. I have to cough out mucus and blow mucus. And if I use the inhaler, I get sores in my mouth.
You get sores in your mouth. Okay, let's hear what the doctors say.
I think what it is that one needs to see a caregiver of any sort to see why there is a precipitation or an exacerbation. It could be flu, it could be a viral infection, it could be all the other things that we have mentioned. And then thereafter, they will be able to say to you, this is how we must control it. But she needs to get it sorted and controlled, because then it can get worse into a very severe asthma that requires that. Now, to come to the sores, we know that you can get sores if you use the pumps, but what it is where the spacer comes in, and also that after using the pump, she must drink a bit of water to wash down the medication at the back of the throat. That prevents the candida that forms in the sores.
We'll talk a little bit about that, you know, in the next segment, but essentially she needs to go back to her doctor to say...
It's always advisable so that they can then see, is she worse, is she the same, is there a change? Because there are other things that can make the control be difficult, and you need other medications to improve your control.
Right. Haley, your thoughts on association between asthma and other conditions?
Thanks for this question. I think the one that I want to bring to light is the association between asthma and severe food allergy. It's something that we're trying to put out there in our writings and the treatment action plans that we're looking at. So in severe food allergy, you're at risk of anaphylaxis, which is a systemic effect on the body and can lead to death. And often that is comorbid with asthma. And if you have the two conditions together, you're much higher risk of fatality. The piece that I want to bring in here is that they can get confused. And this is what I really want us to hear, is that if you're having an anaphylactic reaction, very often people with asthma and or allergy assume that it's an asthmatic reaction and not anaphylaxis, and they would treat for asthma. And there was a case in the States where the woman ate peanuts, thought she was having an asthmatic reaction, treated for asthma, and of course she died because she didn't use the adrenaline which she needed for the anaphylaxis.
And she probably had the adrenaline pen in her bag and never used it.
Of course. So that's something I really want to get out there to our community to be able to discern and to know how to treat. And I would assume, and I'd pass this on to our doctors, that we would treat for anaphylaxis, which would also then help the asthmatic component to it.
Very interesting. Your thoughts on that, Dr. Knight?
There is a huge interrelationship between food allergies and asthma. And like Haley said, that if an asthmatic has a food allergy, the severity of that food allergic reaction can be fatal. And in terms of percentages, I think that up to 50% of patients with food allergies coexist with asthma. So that's quite a high number. And I mean, allergies in general have just become a burgeoning epidemic. So it's about awareness of the public, and we're so grateful to Haley and to the Allergy Foundation and AFSA for this. And this is what today is about. It's about bringing awareness of all these different kinds of allergies, and just in terms of public awareness and treatment.
Very interesting. Earlier we mentioned that, I mean, obviously we spoke about COPD, emphysema, and so on in adults. But in children, asthma can be associated with other conditions. Tell us a little bit about them.
Okay. I think the biggest associations with asthma and other allergic disorders is eczema. So we talk of what we call an atopic march or an allergic march, which is actually the genetic predisposition in an individual. So if children present early on with eczema and food allergies, their risk to develop allergic rhinitis and then later on asthma is that much higher. So you've always got to look for these other variables and the other diseases in any patient diagnosed with one of the conditions.
But I mean, it's an association. Does it necessarily mean that if you have eczema, you're definitely going to have asthma, or is it just that they're associated?
It's not a definite relationship, and it's not a causal relationship. So what you're looking at is just that there's a higher incidence of allergic diseases grouped together.
All right. Let's say Gogo Anna from Johannesburg. Gogo Anna.
Hello there. Morning. How are you?
Good. How are you, Gogo?
I'm fine, thanks. I've got an allergy. Actually, I just got asthma from a chap that smoked very much at work at one stage. So I've got this asthma, and I've also got allergies now that's developing lately. I am 78 years of age already, and I get this terrible bronchitis, and I get these asthmas as well. And but I get bronchitis very often and goes into my lungs. And when I go into hospital, I must pump all the time, and you know, allergies for smoke, and I'm also getting allergies now for onions and garlic and stuff like that, and pethidine and medicines. And you know, and I don't know, it's so uncomfortable sometimes, because you sit in a just company and somebody's got smells, and you get that all that smells, and I don't know, it's very awkward. So I don't know really what to do, and
All right. Gogo Anna, thank you so much for your excellent questions. Very interesting. We've just run out of time now, and I'd like the guests to keep these questions in mind. We're going to respond to you just after the break. Okay, we go for a quick commercial break. After the break, we talk treatment of asthma. Stay with us.
We've got different types of inhalers which we order. It comes in a box like this. You take it out, you connect it like that. So you're gonna press to exclude. You remove the cap, you engulf the whole tube into the mouth. You spray, you breathe in, to try and push it into the lungs and to the bronchus so that it can open up for about a minute to two. And then from there, you can start breathing out and continue. If you get an attack, because there are those who use it PRN when necessary, but there are those whose lungs are not so well that they have to use every day, in the morning, afternoon. And when you have, sometimes when you get an attack, you don't have to use somebody else's spray because it's your mouth here. We prevent cross-infection.
Welcome back. Yes, we're talking asthma, and we're talking treatment of asthma with my two guests here in the studio, Dr. Muremisi Mukansi, a pulmonologist and head of ICU at Helen Joseph Hospital, and Dr. Meshandri Naidu, specialist pediatrician in private practice in Parktown. Dr. Mukansi, before we tackle treatment, we had a caller earlier, Priscilla, who asked a few questions. I'm just going to ask you to summarize the main points of what she said, because she said a whole lot of very interesting points. Okay. And then, of course, I'd like you to respond, yeah?
Good. I think the salient things that she said is that she's asthmatic. So I take it that she has gone through the rigors of examination history and at least the lung function to make sure the asthma diagnosis is correct. So that's one, and that she has allergies, which, of course, as the pediatrician has said, there's a relationship, and if you have nasal congestion, you can have post-nasal drip, amongst other things, that precipitates an asthmatic attack. The other thing that I want to throw in is I hope she is not on other medications for a high blood pressure that could easily be precipitating the cough, but that's something that the doctors would be very aware of and sort out. And the other thing is that smoking, secondary smoking, which she says she was exposed to at work, seemed to have contributed in terms of precipitating asthmatic. And you must have seen smokers who are not asthmatics, they start coughing when they smoke or when you're next to them and you can cough as well. So that can on its own precipitate an asthmatic attack, and those are the issues that she has mentioned.
Okay.
Now, I'm not trying to throw the responsibility to other people, but I think she needs to have an allergy, for instance, tested by the allergy specialist so that she can know what she's allergic to, and then we'll take it from there.
Okay. Your response, Dr. Naidu?
I think she's mentioned very unusual allergens as well in terms of the food allergens. Onion and garlic is what I heard, I think.
Very interesting.
Very interesting. And I mean, there has been an emergence of these allergens today, novel allergens as well, in terms of causing severe food reactions and even anaphylaxis. So it is advisable that, you know, she has either skin prick testing or prick testing or even a blood test done to confirm these allergies and to be able to then follow a proper elimination or avoidance diet as necessary.
Yeah. The one important thing she mentioned was secondary smoking. And I mean, we haven't discussed the importance of smoking as a trigger factor for asthma attacks. Your thoughts on that?
It is an important trigger of an asthmatic attack. And as much as it can cause the same thing that asthma eventually can cause if it's not controlled. So it means you have bronchitis from asthma and bronchitis from smoking and poorly controlled, so it's a problem. But it's something to be aware of. And I always encourage my asthmatic patients to stay away from cigarettes if they can.
Yeah. What about psychosocial factors as a trigger factor?
I think that is a part that we often forget about. How is the patient taking this all in as a diagnosis? And even as a young child, it puts enormous pressure because now the child has to carry a medication, a pump on him all the time to school. There's anxiety, fear of stigmatization from other children at school as well. And then time away from school, because asthma causes exacerbations, which then causes, you know, children to miss school. They've got to get to doctor visits for follow-up appointments. And then also just from poorly controlled asthma, nighttime symptoms, you know, where a child does not sleep well, which then has a huge impact on their productivity and performance and concentration at school the next day.
All right. Okay, on a slightly different subject, we're now coming back to the treatment. Now, very recently, we saw in the news that there's an award-winning young scientist, a PhD candidate, who invented some very interesting medical digital device called the Asthma Grid. And this PhD candidate is now joining us from our Pretoria studio. Moses Kibalipile. Moses, welcome to Health Talk.
Good day, and thank you for inviting me to be part of this show.
All right. We're obviously proud of your achievement. Could I ask you to please just share with us what this instrument is about and what motivated you to design this instrument?
So basically, the device, it's preventative instrument. It's an early alert system. From the discussions you've had with the clinicians in studio, I think we can really say management of asthma in terms of pharmacotherapy, it's quite sufficient in South Africa. So this instrument is something to be used by clinically diagnosed asthmatics to help them better predict the likelihood of episodes of asthma.
Mm-hmm. Very briefly, so how does it work?
So it uses dissipate sensors, biosensors, and environmental sensors. When we built the instrument or did the discovery on the instrument, we used clinical data where we went to hospitals, Steve Biko Academic Hospital and Baragwanath Hospital, where we collected clinical data on patients who presented with asthma and looked at what were the symptoms. We also collected environmental data from the environmental affairs and mapped presentations at the facility, health facility, with environmental exposures. And from that data, we developed a predictive algorithm using neural networks, where we study or teach the algorithm to predict the likelihood of a presentation with asthma given environmental exposures. So the sensors are environmental and would be real-time monitoring environmental exposures, and the biosensors would be monitoring biological variability or the changes in the vitals of a patient, and together this would be computed into an output, which is the susceptibility or likelihood of an asthma attack.
All right, okay. Let me quickly get, this is very interesting. Let me quickly get your response to this or your thoughts on this.
Quite an innovative, an exciting innovation, because then it means we could be able to preempt acute exacerbations and the expenses that come with someone who has a severe acute asthmatic attack, who may even end up on a ventilator in an intensive care and stay longer. So it's quite exciting. I would want to learn more about it and see how it works.
And your thoughts, Dr. Naidi?
I think we don't have a cure for asthma, so prevention is where it's at. So it's wonderful to see research going into that. And if we can have some novel way in predicting a severe exacerbation, then I think we've won our battle.
Okay, we're running out of time, unfortunately. Just principles of treatment and how people should use the sprays.
I have three things to say. One, I think it's education and developing a good relationship between the caregiver and the patient, so that we know what the patient knows and what the patient doesn't know, and the do's and don'ts of treating asthma. And then two things in terms of treatment is that we have a group that is called relievers, so those that are tight would use that medicines, and maybe those that are exercise induced can use it 20 to 30 minutes before the activity, and then the other ones are the controllers in the persistent asthmatics, which we then would use morning and evening for as long as we think the asthma is still quite moderate to severe.
Right. In children, obviously, it's a problem. Children can't, learn how to, it's a technique that you need to master.
So I think children are not small adults, and that's very important. So we have special devices called spacer devices that are used to enable a child to get the best delivery possible to the lungs. So
and where do parents get these spacers?
So that would be prescribed by your doctor and can be bought at any local pharmacy. But, I mean, in poorer populations where they have no access to this, there have been other innovative ways of building their own spaces using a plastic Coke bottle, for example.
Very
and that has been shown to be quite effective in studies done.
Yeah. Well, time flies so much when you're having fun. Thank you so much for your contribution, Dr. Meshandri Naidi, pediatrician based at, in Parktown in private practice, and of course, Dr. Murumisi Mukansi, a pulmonologist at Helen Joseph Hospital. And we thank, obviously, our guest in Pretoria, Moses Kibalipile, the PhD candidate that invented this very interesting gadget, and we can only wish you well. Thank you so much for your contribution. And to our viewers at home, thank you so much for watching. Thank you for being with us. You can watch Health Talk. Remember, if you missed any of these shows, you can watch them on the YouTube channel, but otherwise catch us next week, same time. Please do take care.